Hello, everyone. Welcome to today's edition of Pathcast. We are extremely sorry for the unavoidable and inadvertent delay in starting the lecture. I hope you all are staying safe amidst these very difficult times for all of us. Today is April 28, 2020. I'm Rifat Manan in Philadelphia, and I'm joined by my good friend Emilio Madrigal, who is in Boston. Today, we are very excited to welcome back Dr. Fausto Rodriguez from Johns Hopkins Hospital, whom you all know from the recently concluded awesome neuropath lecture series that he had for us. Today, he is going to present a glass-slide seminar entitled Update on Selected Neuropathology Entities. As always, please feel free to post your questions and comments on both Facebook and YouTube chat windows. And thank you, Dr. Rodriguez, for joining us today. Over to you now.
Okay, my pleasure to be again with you. Thank you, everybody who has been patient and stayed around for the seminar. So today I'm going to be showing illustrative cases, and as I mentioned briefly, we're going to be focusing on some changes that are being proposed and some updates on brain tumor classification, which is going to be incorporated in, at least in part, for the upcoming WHO, which you'll be hearing more in the next following months. So this is a key report. If you know, we have discussed this before. The C-Impact series kind of gives you updates frequently. These are experts that get together and propose and take a look at what's happening in how molecular pathology is impacting and changing tumor classification. They give updates every so often that are published. I'm going to just show some of the, as you can see, there's a lot of changes that are happening and a lot of recommendations. So this is not going to be verbatim incorporated in the WHO, but there's many of these entities probably, or tumor types, that's the main way to define them now, and subtypes will be making one way or the other there. You can see there's a lot of changes, and one of the main ones is in the diffuse astrocytoma category, where the IDH mutant astrocytomas are graded now from grade to 4, but using the Arabic numeral is going to be a big change that is upcoming. And of course, the ongoing emphasis on incorporating molecular findings or typical molecular drivers into the tumor names. These are some that are, there's a lot of consensus that will be distinctly enough to be incorporated as new entities. Then there's names that have been modified a little bit, like choroidal glioma. It used to be choroidal glioma of the third ventricle. Probably is going to be simplified as choroidal glioma, and slight name changes for example, supratentorial ependymoma, etc. There are some in the Utrecht meeting. There were some cases that or types that were discussed, but with no name or recommendations. And then there's a list of tumors or that are still waiting for more evidence to come to make a decision. And many of these are based on molecular types or subtypes. So let's start with case 1. We're going to go through actual cases that illustrate many of these concepts that are happening. So this is an ongoing process. So please just keep reading the literature and keep looking for updates as they come. The first case is a 40-year-old man presenting with tonic-clonic seizures 5 years prior. The biopsy at that time demonstrated a diffuse astrocytoma grade 2, and the patient was followed with imaging only. This is the representation of the imaging. On top row, you have a T2 and a T1 with contrast, and you can see you have a lesion here in the right frontal lobe that does not enhance. And after it was resected, and you can see that there is increased signal on T2 and some contrast enhancement happening in the tumor bed. And remember that there's no treatment here, so many of these changes you cannot ascribe them over time to radiation or the effect of treatment. So this is actually very concerning in this case. Okay, and here is the H&E. You can see a low power. The cellularity is worrisome. Remember that we already have a diagnosis of grade 2 astro with IDH mutation. So your main role here is in the same location as the tumor bed. A second surgery is to see if the tumor has stayed the same or has changed. Here, the effect of treatment is not an issue, but occasionally that's something you have to have in mind. And you can see here that the cellularity is worrisome, and you start seeing some also worrisome vascular changes. We still confirm that you do have an astrocytic neoplasm that is infiltrating. Here, more of these worrisome. This is really convincing microvascular proliferation. Always something worrisome in when you're dealing with diffuse gliomas. And you start seeing some necrosis that has actually pseudo or palisading quality. We have some immunostains here also to show that neoplasm is positive for OLIG2. It's a frequent marker for glial tumors that we use. IDH mutant protein is positive. Wanted to confirm that the tumor indeed still has an IDH1 mutation, and the initial diagnosis was correct of an IDH1 mutant tumor. There is strong p53 staining, which also goes with these IDH mutant astrocytomas. And this is ATRX. So you do have here loss in the tumor cells with some preservation in internal control cells that are non-neoplastic. And Ki67 is increasing. So we are seeing all features that tell you that this tumor is progressing now. It's different from what it was. And it goes well with the imaging abnormalities described or that I showed you earlier. So per new recommendations, this is where we're going to go with time. The astrocytomas will be given a grade that is numerical and use Arabic numerals and IDH mutants. So the IDH mutant astrocytomas will be grade 2, 3, and 4. Now, still we use the WHO, still is the formality is to use the WHO since it hasn't changed yet. It's not out there. So it's still, until you have a new classification, this is still acceptable, which is glioblastoma IDH mutant WHO grade 4. In practice, I am using kind of both numbers. I may put it on top glioblastoma IDH mutant and say in the comments that this is new recommendations are moving into grading astrocytomas in a 4-grade trial. So it's a good way to also educate your clinicians and to make sure that they understand that there's terminology that is changing, but this is what we are technically seeing. And again, it's still okay to use the WHO for in many instances. This is still what is the current consensus. This tumor was sequenced and it had several mutations. And something else that is going to be also important for the IDH mutant tumors is the presence of P16 or CDKN2 alterations is going to be used to upgrade tumors that historically may appear grade 2 or 3, but the presence of P16 mutations really affect prognosis, are a bad prognostic factor that are sufficient to upgrade the tumors to grade 4 now per current recommendations. So it's something that is to have in mind. Next case is a 66-year-old male with a history of metastatic prostate cancer. And as part of the cancer protocols, it was follow up with serial imaging, and they found this. So you have a lesion that in flaring T2 has a signal, increased signal, and you have ring enhancement in T1 weighted imaging after contrast administration. Okay. And again, we are seeing here a infiltrating astrocytoma. You do have angulated cells, hyperchromatic, infiltrating brain parenchyma. You have necrosis. It does have a bit of a palisading quality and quite a bit of hypervascularity. Increased vascularity. In this case, I'll show you exact some of the stains that we did, as similar to the other panel that we had for the previous one. This is OLIC 2, strongly positive. Mutant IDH1 is negative. P53, rare cells. ATRX is a little bit of failure, but in areas that are intact, you do see that there is intact expression of ATRX. Very different from what the first case that I showed you. Ki67 labeling index is similarly increased. So the diagnosis here is glioblastoma IDH wild type. It's a great panel to immunohistochemistry that can give you a lot of information to start with. This was also subjected to NGS, and it does have EGFR amplification. MGMT methylation was not detected. So glioblastoma IDH wild type will be it's still a category that is going to be preserved, and mostly for the tumors that do not have IDH1 mutation. Now, what would have happened if these didn't have necrosis or microvascular proliferation or any other histologic features of glioblastoma? These will have still qualified for glioblastoma in this new proposal, because you do have EGFR amplification. If you have a diffuse glioma in an adult, a diffuse astrocytoma that has EGFR amplification, even if it appears grade 2 or grade 3, it will be sufficient to call it a glioblastoma. In the past proposals, this was called a diffuse glioma with molecular features of glioblastoma, but eventually the recommendation now will be to that, since the prognosis is very similar, that you can satisfy glioblastoma by histologic criteria, as long as you document that you have an intact IDH gene. But if you have EGF amplification or TER promoter mutation or whole gain or chromosome 7 and loss of chromosome 10, those are the three possibilities that you have, molecular possibilities that will get you to glioblastoma even when you don't have histologic criteria for it. Moving on for the next case, this is a 40-year-old woman with worsening memory and fatigue, progressive brain mass. So 2 years prior, the patient had this abnormality that was actually inside the ventricle that was resected and now started to grow and develop a lot of edema, and actually started to getting some worrisome enhancement. It actually seems to be even extending outside of the ventricles now. So this is what we have here. A tumor that is also cellular. You do have some hypertrophic vessels, or what we'll call also microvascular proliferation. And the tumor is glial. And even more precisely, astrocytic. You have an astrocytic phenotype here. In contrast to the other cases that I was showing you before, infiltration is not very obvious here, and the cells have a bit more hypereosinophilic processes. And sometimes that's what we refer as a pyloid in some ways, a pyloid morphology. It's not completely specific, but it's something that at least you have to have in mind when you start seeing, even in the absence of horizontal fibers, you have to start thinking whether this is has a pyloid origin. There is necrosis. And again, this tumor was not, that was not treated. You do have some infiltration as well. You probably have some axons there. So but here it does have more of a pyloid appearance in some ways. There were areas also with brisk mitotic activity, which is important. Goes well with an increase in Ki67. This Ki67 is increased also in Apache fashion. GFAP very strong, not surprising. We were suspecting this to be glial based on the morphology. And then a few additional stains that were helpful in this case. This is P16. P16 immunohistochemistry is not as robust as the molecular characterization, but we do see here some quite a bit of loss on the tumor with preservation in vessels and hair cells. More importantly, we are seeing ATRX loss. That's going to be relevant. So we have a tumor that is somewhat pyloid appearing and has ATRX mutation or loss by immunohistochemistry and P16 loss. Now we went back and reviewed the original resection, and it's even more overt here that this is really a pyloid neoplasm, and you have really good, even more hypereosinophilic processes with horizontal fibers. We here have no issues calling this pilocytic astrocytoma, and that's how it was interpreted at first biopsy. And in retrospect, we went back and ordered also ATRX, and it was actually lost also in this precursor. The loss is something to have in mind. The loss of ATRX is extremely worrisome in a pilocytic astrocytoma because it's not typical of your conventional neoplasm. It's something that we see it's more characteristic. The loss of P16 and the loss of ATRX in pilocytic astrocytomas that actually go bad. And that's, in this case, we call it pilocytic astrocytoma with anaplastic features. So this is a debatable category. It's not recognized by the WHO. So this is a rare phenomenon, usually restricted to pilocytic astrocytomas that occur in adult patients for the most part. It's much more common when it happens in adults, but it's a rare phenomenon overall. And is still the data on prognosis is still being developed. So what has been suggested to be part of upcoming classifications is something that has been called high-grade astrocytoma with pyloid features. In some ways, there's some overlap between them. Many of those high-grade astrocytoma with pyloid features do satisfy histologic criteria for pilocytic astrocytoma with anaplasia, but it is more of a molecular entity in a sense that, or subtype that was defined on the basis of global methylation profiling. So, and there are tumors that do not have a histologic appearance that will suggest pilocytic astrocytoma, but that will fall in that category, will have some of the same alterations like MAP kinase pathway alterations, NF1 mutation or BRAF fusions, plus ATRX loss and RP16 loss. So you have tumors that look like a high-grade astro. They don't look at all like a pilocytic astrocytoma, but will fall into that category. So it's a broader category, but many of the tumors that we call pilocytic astrocytoma with anaplasia will probably fit into that category. So the terminology will be probably more along those lines of high-grade astrocytoma with pyloid features. But the message here is that sometimes you can recognize certain tumors on that histologic basis as having developed from a overtly convincing pilocytic astrocytoma precursor, or that you can see either in a prior tumor or in concurrently with a neoplasm, with a high-grade neoplasm. Case 4 is a 32-year-old woman that presented with seizures. This is the T1 with contrast coronal. You can see there is a abnormality here in the right frontal lobe that has some subtle enhancement. And here we have another high-grade astrocytoma or high-grade glioma appearing thing, or let me see, actually, we're not even there yet. You have a malignant neoplasm, actually, that has quite a few mitotic figures. So it is proliferating. You can argue that there are some cells that have high nuclear cytoplasmic ratios. So an embryonal neoplasm is still in the differential diagnosis. More here. Although you can argue that there is a background of fibrillary processes. Mitotic figures are easy to find. So fairly looks pretty much similarly all around. A few halos here and there, but definitely very cellular. And mitotic activity again is not subtle. We did a panel of immunostains as well in this case. This is GFAP. So the tumor definitely shows GFAP expression. IDH1 is negative. synaptophysin is negative in tumor cells. This type of pattern is very characteristic of entrapped axons. It's more of a feature of infiltrating gliomas. So even though the appearance, you still had an embryonal neoplasm at the histologic level as a possibility in the differential diagnosis. You have strong GFAP and no real good convincing synaptophysin positivity in tumor cells. That makes it more, puts it more in the category of a glioma. This is Ki67. It shows a elevated proliferative index. And there are other markers that also give you some clues. This is OLIC2. And as you saw in the other cases, OLIC2 is a very frequent marker and very practical marker for glial tumors. This one, you have rare cells here. Some of these maybe even entrapped. So most of the tumor cells are negative. P53 is strongly positive. And ATRX is lost in the tumor cells. So that combination, the phenotype is actually very suggestive. So you have a high-grade neoplasm that we are showing that has a glial phenotype and lacks OLIC2 positivity, has strong P53 positivity, and has ATRX loss. And here is the diagnosis. So this tumor actually was confirmed to have a H3, histone H3 G34 mutation. And so this is actually, there is a lot of indications that this is going to become a category on its own, because this is a really different tumor type. It tends to occur either in children or young adults, and tends to be hemispheric. Remember that the other tumors that have histone mutations are the diffuse midline gliomas. That was part of the previous WHO classification, 2016. And those tumors have actually a K27M mutation for the most part, which is they're highly aggressive. These tumors tend to be more hemispheric, and they are high-grade tumors. So it's very important to have in mind that they are high-grade tumors. They may have a better prognosis than diffuse midline gliomas. That's what some of the retrospective data shows. But they have this characteristic G34 mutation and a very characteristic phenotype, characterized, as we mentioned, by the lack of OLIC2 expression, strong P53 mutations and strong P53 staining, and ATRX loss. That combination is highly characteristic of this tumor. They still preserve GFAP, and they may have sometimes a more primitive appearance on histology, but they are definitely glial neoplasms. Next case is a 30-year-old man with no neurologic history and died secondary of trauma. This was actually an incidental finding in the right anterior temporal lobe. And of course, these specimens that you obtain an autopsy give you a better perspective regarding the anatomy. Here you have a large piece with a gyrus and white matter, and you have something that looks pale at low power. Now here the orientation is very helpful because you have gray matter here, and deeper you have the white matter, but you also have these little nodules here. And in these nodules, what you have is vacuolation, and these cells appear they appear neuronal, have neuronal type nuclei, but something that is subtle is that they have a bit more slightly eosinophilic cytoplasm. you have more than one nodule, and you have vacuoles. Very low grade, no real glial component to this lesion. So it's a neuronal lesion, nodular, and composed of cells with vacuolation. So the diagnosis here is multinodular and vacuolated neuronal tumor. It's a rare neoplasm. Occasionally it presents as seizures. Okay, like in this case, it could be incidental. They are very slow growing. And it's also, there was some debate whether this was some sort of a so low grade appearing and so mature that there was debate whether this represented a more of a malformative type of process or a true neoplasm. And there's recent evidence that have shown clonal mutations in these tumors, particularly in the MAP kinase pathway. So it is also likely to, it's a neoplasm, and it's likely to become a category on its own in the upcoming WHO classification. Case 6 is a 50-year-old woman presenting with dizziness and alterations in balance. And here you have an alteration, a mass actually in the posterior fossa on a T2 image, maybe some cystic change. And this is the H&E. You have, remember where you are, it's a location, is in the posterior fossa, kind of cystic. You can argue there's oligoendoglial-like morphology. The areas that are more glial appearing. Maybe some degree of glomeruloid vasculature, which is something, of course, I showed you some examples in diffuse astrocytomas. This is a finding that is worrisome when you see it in a diffuse glioma, but when you see it in a lower grade circumscribed neoplasm, they have no prognostic significance, and in fact, they are kind of part of that process. You have different fragments. And here you have some areas, you can have this very subtle indication that probably you are dealing with some with neuropil and some of these in this oligodendroglioma-like neoplasm. Oligodendroglioma isn't the differential diagnosis morphologically, but remember that oligodendrogliomas almost never occur in the posterior fossa. So that is something to have in mind. And molecularly now they are distinct. So this was actually, there was very scant material in this case. But so we had some morphologic features that to us were suggestive of rosette-forming glioneuronal tumor. There was so scant material that actually we decided to use it mostly for NGS in this case. And the tumor had actually a couple FGFR mutations, one at least that has been reported before in these rosette-forming glioneuronal tumors. They tend to have FGFR alterations, sometimes in the form of mutations or fusions and or rearrangements, and also PIK3CA mutations. So there are certain molecular alterations that are more common in these. that was at least helpful in a sense that sometimes the rosettes may be subtle, and particularly when you don't have enough material. In this case, we went a little bit directly for a molecular because of since there was very scant material. Now, I want to show you a better illustration of it. So this is another case, just to show you what a more classic case looks like. Oligoendoglioma-like morphology. There's a lot of these tumors that are glial and glioneuronal, low grade, predominantly pediatric, that you will see that have an oligoendoglioma-like morphology. So remember now that the oligoendoglioma is more a molecular characterization. So this tumor, the previous tumor that I showed you, and this one, they don't have IDH1 mutations. They don't have 1p19q, something to have in mind. But here, these are the rosettes of the tumor that I've already developed in another example. It's a tumor that had more material. And you can see here that the rosettes are much more well developed. And this is the immunostain. So these are the rosettes. So this is a very classic, convincing case of rosette-forming glioneuronal tumor that you can identify by morphology in some cases. In some instances, like in the case that I showed you, you can have a fragmented neoplasm. So it's good to know where you are anatomically, and also sometimes the molecular profile can help you a little bit, point you in that direction. Why I'm showing this is a tumor that actually was incorporated in previous WHO classifications. The reason I'm showing is that we now we're learning more about the spectrum of genetic alteration of these tumors, and you will see several categories of tumors that have FGFR alterations, and this is one of them. Moving on to the next case. The patient is a 5-year-old boy that presented 1 year prior with vomiting and gait changes, underwent resection of a posterior fossa mass, but now has a new onset of neck and back pain. And this is where you have a very cellular neoplasm. When you see this at low power, well, or even a high power here, you are concerned, particularly at high power, that this could be some sort of embryonal neoplasm. Medulloblastoma of some sort of embryonal neoplasm is the first thing that comes to mind based on the cellularity here. But looking around, that's why sometimes you have to go back at low power. You start seeing that the pseudorosettes, which we refer to this clearing around vessels, is very conspicuous. You have a lot of pseudorosettes. And mitotic activity is brisk. So you're dealing really with a malignant neoplasm. They are not subtle, the mitotic figures. Another one there. Here, immunostaining is a good way to approach it first. We can start with GFAP, and you see that the tumor indeed is GFAP positive. Including in the areas of pseudorosettes here around the vessels. OLIG2 is negative. Synaptophysin is negative. So here, and convincingly so. There's not also, so there are also, the synaptophysin here is useful for two different reasons. One is it's negative in the tumor cells, so it tells you that most likely it's not a medulloblastoma, right? So, but also you're not seeing much for axons. So it tells you that it's more of a solid neoplasm. So you have a very solid neoplasm that lacks axons, is GFAP positive, and it's OLIG2 negative. And this is suggestive, highly suggestive of ependymoma, if not diagnostic. I will say that it's almost essentially diagnostic in combination with the morphology. You have a GFAP positive, OLIG2 negative neoplasm that it has a very solid pattern of growth. This is EMA. And sometimes you have to spend quite a bit of time before you find some of the microlumina or dot-like positivity that is typical of this tumor. You don't always have it. So if I recall correctly here, they were very subtle. But really, you don't need it in every instance. Just spending a little bit of time. You can see how subtle it can be, EMA. And in fact, here I don't see any good ones. Ki-67, leveling index, very high. So this is definitely an anaplastic neoplasm. Then we did immunostain for H3K27 trimethylation, which is lost in this tumor. What can be the cause of it? One is the diffuse midline glioma, H3K27 mutant. So this, we did it in concert with H3K27M antibody here. It's giving you a little bit of artifactual staining in vessels, but this one is the mutated antibody. The one that is for trimethylation is this one here. So it's definitely preserving vessels and loss in the tumor cells. So and this is the here, the imaging. You can see you have a tumor that is actually compressed in the spinal cord. Remember that the patient had a tumor resected before in the posterior fossa that now has apparently seeded. So the diagnosis here is posterior fossa ependymoma, pediatric type, posterior fossa type A. So there's a type A and a type B. The type A are more aggressive, as this case indicates, and these were recognized by gene expression profiling and methylation subgroups. So, but one good surrogate for the posterior fossa A is this loss of H3K27 trimethylation. So it's a very practical immunostain that allows you to identify. Remember that this loss of it happens in many different tumor types. So it happens in diffuse midline gliomas, it happens in MPNSTs and other things, but it's so you need to have it in context. But in this, when you have this differential of a posterior fossa ependymoma in children, this is a useful separation, which is the posterior fossa A versus B. Some of them also have other alterations that are worrisome, like gain of chromosome 1q. But they tend to be more aggressive. Something also that you notice is that there's a suggestion the anatomic location of ependymomas is a very important feature that allows you also to subclass a tumor. So a tumor, an ependymoma of the posterior fossa is different from an ependymoma that is arising in the spinal cord as a primary. Remember, this is in the spine, but it's a seeding from a posterior fossa one. So it's something to have in mind that now the anatomic compartment where the ependymoma develops is going to be part actually of its classification, something that was suggested in these as updates for these upcoming classifications. Next case is a 4-year-old boy presenting with seizures and a right temporal lobe mass. And you have a tumor that's very cellular. It's blue at low power. You have these cells with high nuclear cytoplasmic ratios, mitotic activity, a few halos, but it's really a very proliferative neoplasm. So something to have in mind. You do have probably a suggestion of neuropil in areas. Cellular. There were a few markers done. This is OLIC 2. It's positive for OLIC 2. I don't have the synaptophysin, but it was also positive for synaptophysin. This is here slightly weak around, but this is I91, and it was interpreted as being preserved. This is when it's preserved. It's a little bit weak, in some ways artifactual, but it's definitely preserved. So you need to exclude an ATRT in many of these embryonal neoplasms when dealing with pediatric tumors. Synaptophysin was also positive. So we are dealing with an embryonal neoplasm, and this is a group now that there's going to be a lot of changes as well, because this we used to be placed in the umbrella of PNET or CNS primitive neuroendothelial tumor. That term was actually dismissed in the 2016 classification. Now what is being added is additional layers of molecular alterations that associate with different subtypes. This one actually happened to have a FOXR2 alteration, and that goes with the morphology of a CNS neuroblastoma. These are better differentiated neoplasm in this spectrum of embryonal tumors. They're felt to be associated with a better prognosis, comparatively speaking, with in contrast when comparing to other embryonal neoplasms. And again, this is a lot of this. This is a group of tumors where the molecular characteristics are going to play an increasing role in classification and stratification for pediatric clinical trials. Case 9 is a 10-month-old boy presenting with rapidly progressive symptoms, including vomiting, respiratory distress, and seizures. You do have quite a bit of necrosis, and again, you have the appearance of a tumor that at low power is a little bit fainted now, but a tumor that appears blue and has brisk mitotic activity. Mitosis are not hard to find. So again, we're going in the direction of a round blue cell tumor that was hemorrhage and also hemosiderin laden macrophages, going again with a high-grade neoplasm. Very cellular. And here also, this one actually was negative for synaptophysin, but it was positive for CD99. And here was another case in which molecular played a role. And this was actually had a CIC rearrangement, and it's part of this family of CIC sarcoma. So some of these were identified. These are, the literature is more developed in the soft tissues, where you have these round cell tumors that have a lot of overlap morphologically with Ewing sarcoma, but instead of EWS rearrangements, have CIC rearrangement, most commonly these DOX fusions. But in the more profiling that's happening now in the CNS, has also identified that a small subset of tumors that may even be placed in the embryonal category or in the former PNET type of category, now we know can have these rearrangements. So the terminology will be very similar, reflecting those that happen in the soft tissues. Not an embryonal neoplasm, even though it's part of a very important differential diagnosis on embryonal neoplasms. It's probably the same spectrum of these sarcomas that can also involve the CNS and that are being identified more and more now that more profiling is happening with these tumors. That takes us to the last case, which is a 38-year-old man with headaches and signs consistent with increased intracranial pressure. And this is what we have: a mass that is not subtle, and to occurring in the suprasellar region and third ventricle. And it's a bit fragmented. But you start, the morphology here is actually highly characteristic of this rare neoplasm. What is the architecture? Is the formation of cords by these eosinophilic cells. You have a sprinkling of chronic inflammation around, also highly characteristic. A myxoid stroma. Even here, in some areas a bit more hyalonized, but you do have some myxoid changes as well, and the formation of cords. This morphology in combination with the location kind of suggests the diagnosis. This is GFAP, which is positive in tumor cells. So it has a glial phenotype. OLIC2 is negative. EMA is positive in a subset of cells, which also has been described in this neoplasm. Some of it, I think, is plasma cells here. But you do have some positivity. Very weak in slightly membranous in some areas, but mostly limited to the chronic inflammation of the plasma cells. More importantly, this is TTF1, which is positive. And TTF1 expression is something that has been increasingly recognized in tumors that affect the suprasellar region, and like in this case, the third ventricle. So this is actually a choroidal glioma, and this is a slight change that has been proposed that it used to be called choroidal glioma of the third ventricle. By definition, almost this tumor arises there, so it was for simplification. It has been proposed to be used to be called choroidal glioma. Molecular, we know that this is a distinct entity as well. Dr. Solomon and colleagues in UCSF demonstrated that these have recurrent point mutations in PDGFR alpha. So it is a molecularly characterized entity. So that takes us to the end of the cases. As in other presentations, we are going to go over some multiple choice questions to refresh some of the information that we have discussed here. So first question, 25-year-old male presented with a seizure, MRI demonstrated a high frontal lobe mass, histologic sections demonstrated an infiltrating astrocytoma, IDH mutant with ATRX loss. Which of the following alterations has been incorporated into proposed grading criteria for this subgroup of tumors?
We are waiting for the answers. Let's see. I can see more for B as in boy, that is EGFR amplification, and one answer which is also for C, that is CDK and 2A deletion.
So the correct answer is C. And we discussed both alterations. So in the IDH mutant tumors, a presence of P16 or CDKN2 homozygous deletion, that will be suffice to place it in the grade 4 category. So that is being suggested, the prognostic significance is strong enough that it's presses the tumor to be in a high grade category. That's grade 2 or grade 3, particularly grade 3s. So something to have in mind, EGFR amplification is used as a criterion for glioblastoma IDH wild type. It's not in the IDH1 mutant tumors. When you see it in a diffuse astro, that it doesn't have IDH1 mutation, that suffices to put it in the grade 4 category, in the glioblastoma category. Question number 2. What immunohistochemical marker is a useful surrogate for the posterior fossa ependymoma pediatric type A?
We are still waiting a little bit. Let's see. It seems there are more answers for E, that is synaptophysin, but it's varied somewhat. There are some answers for C as well, that is H3K27ME3. It's variable, but there are more for C and E.
Okay. So the answer is actually C. So the loss synaptophysin is more of a marker of embryonal neoplasm. So it should be, for the most part, negative in ependymoma. Not only in the tumor cells, it's also, remember that ependymomas tend to be more circumscribed neoplasm. So you will also, it gives you a feel of how solid the tumor is, which is more of a feature of ependymomas. But the one that differentiates the type A from type B is the surrogate marker, which is the loss of H3K27 trimethylation. For the most part, they don't have the K27M mutation, with some exceptions. There's a small minority of this subtype also that has, in addition to the loss of the K27 trimethylation, has a mutation in K27. But for the most part, the surrogate marker is actually the loss of H3K27 trimethylation with preservation in intact non-neoplastic elements. Question number 3, which of the following alterations in embryonal neoplasm is associated with a cerebral neuroblastoma phenotype? And there's some suggestion of a better prognosis as well.
The options are more towards B, that is FOXR2 activation.
Great. So I'm happy to see that you're paying attention. So yes, so this is it's going to be a new category. It's associated with this cerebral neuroblastoma-like morphology. Which in contrast to the other tumors represented here has a better prognosis. The C19 amplicon, remember, is associated with ETMR, embryonal tumor multilayer rosettes. It's a bad prognostic alteration in embryonal neoplasm of the CNS. The same can be said of amplification. SMARS-B1 or I91 mutations recognized as ATRTs, which are bad, and P53 mutations, you see it in a variety of tumor types, both glial and embryonal. The final question, we didn't go much onto these, but this is another subgroup of tumors, low-grade, usually seizure-associated, the polymorphous low-grade neuroepithelial tumor of the young or plenty. So this is a bonus question. It's characterized at a molecular level by
More answers are pointing towards A. So the answers are more towards A, that is BRAF KIAA1549 fusion.
Actually, it is C. So sorry, we didn't cover this one, but it's part of this list of proposed entities that are likely to make it into the future classification. This is a tumor that actually is low grade, oligo-like. So the theme here is that you have many of these oligoendoglioma-like low grade glioneuronal / glial tumors. Some of them, they are favored the young patients, children, and they tend to have various types of FGFR alterations. The one that you see associated with plenty usually are fusions. So you do have some occasional ones that have BRAF alterations, but they don't have the BRAF KIA fusion that characterize pilocytic astrocytomas. So this is the end of the questions. Something I wanted to clarify, I misspoke earlier in the last case that I showed you, the chordoid glioma. The chordoid glioma are actually associated with mutations in protein kinase A alpha. So they have recurrent mutations in that gene, which I misspoke earlier. So it's now considered not only a morphologic, clinical, but also a distinct molecular neoplasm. Any additional questions? I'm happy to stay around to answer them.
Yeah, there are quite a few questions. So let me read at least a few of them that so one question is how to classify tumor as P53 wild type or mutant type? Is it immunostain based or molecular based? If it is based on immuno, what is the criteria?
Yeah, that's an excellent question. In P53, it is relevant. There's the main place where it's going to be important and relevant for these classifications is in the Sausage hedgehog activated, a subgroup of Sausage hedgehog activated medulloblastomas. So P53, typically the P53 mutations are associated with increased level of the mutated protein, so you detect it by immunohistochemistry. So if you have a very strong staining for P53, that suggests that you have a mutation. Now, the lack of it's not the same. So you can still have mutations that lead to complete loss of the protein. So strong P53 mutation goes well with mutations, with many mutations, but the lack of it, you can still have a mutation there. It's just something to have, a caveat to have in mind. It's not like these other mutant-specific antibodies, like for IDH1, where it's very specific for the mutated protein, H3K27M, also very specific for the mutated protein. So P53 is it's not as specific or sensitive as these other mutant-specific antibodies. How I approach it is if you have a Sausage hedgehog mutated medulloblastoma, you have strong P53 staining, I suggest that this may be mutant, because those tumors that have this mutation tend to be associated with a very bad prognosis. So the gold standard still is sequencing for these, but if you have very strong staining and you have other features sometimes that make you think of it, for example, you can have some anaplasia. The presence of anaplastic features in a Sausage hedgehog tumor actually suggests that this is in this category of medulloblastoma, Sausage hedgehog activated, and P53 mutant. So it's a surrogate, but I will not use it as an unquestionable diagnostic result when you have positivity for it.
There is another question that was from the early part of the lecture. It is it possible to differentiate gliosis and low-grade glioma by immunostain? And if yes, please mention.
Well, yes, that is actually one of the most important questions that you have to deal with on a daily basis in surgical neuropathology, separating something that's gliosis. I will say the main question, I will rephrase it a little bit differently, and the practical problem for the most part is usually if you are dealing with something that you can definitely call tumor, or you're dealing with a specimen in which you have a slight increase in cellularity and you are still considering that you are at the edge of the tumor that is not very representative. So that's a question that comes up more. The answer is yes, with caveats. If you have strong IDH1 mutant protein expression, the tumor has an IDH mutation, R132H, that's a specific type of IDH1 mutation. Yes, if you have a very good stain for it, you can certainly use it to diagnose neoplasm. If you're very convinced, you have to make sure that your antibodies are working well, that you have a morphologic correlate, that you really are seeing atypia, go back to the scan. So you have all those components together. It is as close as you can have for a marker of neoplasm in the tumors that have that mutation. The same can be said for H3K27M. If you have that, it's a mutant-specific antibody. If you have all the features, you have the ATPI, you have the imaging, and you have cells that are positive, you can actually make the diagnosis in very small biopsies. So yes, now for the most common tumors, which are glioblastoma IDH wild type, is different. In those cases, you can use you still don't have a good immunomarker that will recognize those, unfortunately. So I always recommend you have to have a combination of features. Not good to make a diagnosis just based on a marker, but if you can use it in something, IDH1, H3K27, if you are convinced that your antibody is working well, it's as close as you get to a tumor-specific antibody in the realm of glial tumors.
So there is another question related to IDS1 that's, I think, coming from India. So IDS1 immunostain is very expensive compared to other stains. Molecular profiling is relatively cheaper. So direct NGS or molecular profiling, can we do it avoiding immunostain?
That is fascinating. So certainly, yes. The answer is yes. It's usually easier for us, at least in the United States, to start with immunos. And actually, I do that a lot. I mean, I start with the immunos. But if you have problems with that, and it's easier for you to do sequencing, your quality controls are in place. Is certainly going directly to the sequencing may be a better option. You have the possibility of getting other markers, and also it will cover other IDH mutations that are not picked up by the antibody. The antibody only picks up R132H for the most part, which is the most common mutation, but it doesn't. Sometimes you really have to do the sequencing anyway. So that's why I show a case of a Jose-forming glioblastoma tumor here that had very scant tissue, which I directly went for sequencing. I didn't even do the neuronal markers because I felt that was very little, and the molecular probe will give you targets and other things that you will not be picked. So yes, I think more and more it's very good if you feel comfortable with your morphology and you know what you're dealing with in a sense of differential diagnosis. Going for molecular is a very good option. If you feel that it's cheaper, it's even you have a greater advantage there of going there and doing it. So you don't really you can go for sequencing. Sequencing take a little bit more time. So if you're that's the only drawback of it. But if your oncologists are fine with that, I will certainly see a more value of going directly to sequencing rather than adding stains, depleting the tissue, and actually getting more information from the molecular.
So one other question is that it's more of a comment, I guess. It would be good if you could discuss the mechanism of loss of H3K27ME3 in ependymoma versus midline glioma, since it has prognostic significance.
A fascinating question. So in H3K27M, the mechanism is known, and basically you have a mutation in the site that it occurs, and actually, so the mutation happens at the same site. So that is related and alters the methylation profiling. Too far as I know, I haven't delve very deeply into the ependymomas, but these tumors don't tend to have a lot of mutations. They tend to have a lot of alterations in their methylation profiling. So it's more of it's an epigenetic mark. I don't remember if the mechanism is known. For the K27, it's better explored. It's in that location. You have a mutation in that histone that leads to this epigenetic change. In MPNST, or malignant peripheral nerve sheath tumors, the mechanism there is also known. You have mutations not in H3K27 or the histones, but in the polycomb repressive complex, which are the proteins, the complex responsible for methylating H3K27. So there, it makes more sense, the mechanism as well. For ependymoma, I'm not sure. I'm sure that there are people who are looking at it very carefully, and there may even be data out there. But to my knowledge, it's not like you have a specific mutation that explains why it happens. And remember, these categories were not identified just by specific mutations. They were actually described. The posterior fossa ependymomas type A and type B are more based on gene expression and global methylation profiling. So these are it's not as simple as a simple mechanism as you have in the diffuse gliomas and in MPNSTs.
We have a lot more questions. I don't think we will have time to answer all of them. Maybe one last question we can take. This is regarding, do you recommend doing P16 and ATRX on every pilocytic astrocytoma?
That is an excellent question. In the past, I would say no, because I would like to see that you have other features that are worrisome. It depends on what your resources are. If you do it, I do it. P16, I don't do it as much, to be honest, but if it's a pilocytic that is behaving a little bit more aggressively or have some features that bother me, yes, I will add it. ATRX for me is more valuable because when you have loss, you really can pick it up. P16 is better evaluated by molecular means. The immunostain I showed you in one case, and that was obvious, this case that's an example, but it's not as robust as the molecular. But for ATRX, I do it, and I am doing it. I'm doing actually immunohistochemical panel for essentially, if I have enough tissue, like I mentioned, I will do it for every glioma that I see. So I will do OLIG2, P53, ATRX, IDH1, Ki67. I will do it routinely in every glioma that I see that has enough tissue. If there's very, very scant tissue, sometimes, as the previous question showed, I will go probably directly to sequencing. But I will certainly do it. And the reason now is that that case also illustrates, there are some pilocytic astrocytomas that develop anaplasia, in which you can actually go back and do it in the precursor where you don't recognize any anaplastic features, and you will see ATRX loss. So if I have a pilot that has ATRX loss and is convincing, I will make a comment. I will not call it necessarily anaplastic, but I'll say that this is a worrisome finding, and that actually maybe that is associated more with tumors that actually undergo malignant change.
I think that would be it. So though we have a lot more, but we probably have run out of time for more questions. Sorry about that. And once again, I would like to thank Dr. Rodriguez for taking your time and discuss all these excellent cases, and also taking time to answer so many questions from our viewers. And you would be so happy to know that we had thousands viewers from over 30 different countries who have defied time zone, and there were viewers apart from US. So I could see that we had viewers from Yemen, Nepal, Bogota, Guatemala, Bangladesh, South Africa, to name a few, Iraq. Thank you all of our viewers for your support to Patcast. And if you like our lectures, so please follow our Facebook page, that is Patcast, and also please subscribe to our YouTube channel, Patcast. And I would like to let you know that we have a next Patcast session coming up. That's on April 30th. So that's related to convalescent plasma therapy on COVID-19, which is going to be presented by Dr. Ivan Bloch from Johns Hopkins in US. So hope to see you then. And thank you, Dr. Rodriguez, again for your lecture.
My pleasure. My pleasure. See you all next time.
See you all.